Good morning everyone. Today we are going to discuss heparin induced thrombocytopenia. Heparin is a widely used anticoagulant drug for treatment and prevention of thromboembolic disorders. Heparin induced thrombocytopenia remains one of the most important complications. Coming to incidence, heparin induced thrombocytopenia occurs in 0.1 to 5% of patients receiving therapeutic doses of heparin. Patients undergoing cardiac surgery have high rates of HIT compared to the general medical hospital population. In the ANEATHESIA study, that is nationwide in-patient sample study, 0.63% of CPB patients developed HIT and represented the highest risk group. Apart from that, heparin formulation also affect rates of HIT. HIT is less likely to occur in the setting of low molecular weight heparin compared to the unfractionated heparin. That is because ultra large complexes of platelet factor 4 and heparin required for the development of HIT, and this complex is less efficiently formed in patients receiving low molecular weight heparin compared to unfractionated heparin. In addition, heparin induced antibodies are more frequent among patients exposed to unfractionated heparin compared to low molecular weight heparin. The risk with unfractionated heparin was found to be 22 per 1000, whereas it was only 5 per 1000 in patients receiving low molecular weight heparin. Coming to pathophysiology, the pathophysiology of HIT is complex. The heparin is bind with the platelet factor 4. Platelet factor 4 is a cationic protein and it is stored within the platelet alpha granules that is released upon platelet activation. As platelet factor 4 is cationic protein, so it interacts with the negatively charged glycosaminoglycan including heparin, lead to formation of immunogenic platelet factor 4 heparin complex. This complex is bound by IgG, immunoglobulin G, and it binds to the platelet factor platelet Fc receptors, which activate platelet via the intracellular signaling pathway and release of which lead to release of procoagulant microparticles and causing thromboembolic complications. Recent studies have suggested that neutrophil extracellular trap also contribute to thrombosis in patients with the HIT. Rova et al. Found in their recent review of HIT pathogenesis, pathologic molar ratio of platelet factor 4 and unfractionated heparin are required for the development of HIT antigen and formation of ultra large complexes. In this figure is showing the pathogenesis of HIT. As we already discussed that heparin is bound with the platelet factor 4 which released from the platelet alpha granule and it form the platelet factor 4 heparin complex. This platelet factor 4 and heparin complex is bound by IgG and this whole complex is bind with the platelet Fc receptors, and upon binding with the platelet Fc receptors it causes activation of platelet which release the procoagulant microparticles and that causes thrombosis and thrombocytopenia. Now coming to the diagnosis of HIT. The diagnosis of HIT may be challenging, so it requires both clinical suspicion and the laboratory testing. The clinical feature of HIT is first is thrombocytopenia. The hallmark of HIT is thrombocytopenia, which is the most common manifestation of HIT and it is related to heparin exposure. Heparin exposure may be as extensive as anticoagulation during CPB or as trivial as the heparin flush. Most common presentation of thrombocytopenia in HIT is a drop in platelet count at least 4 days following heparin exposure and usually occurs 5 to 14 days after exposure. Minority of patients have rapid onset thrombocytopenia within hours of receiving heparin. However, these patients are thought to have pre-existing circulating HIT antibodies due to previous heparin exposure within previous 100 days. It has been demonstrated that post-surgical patients have bimodal presentation of thrombocytopenia in which there is an immediate platelet drop following surgery that rebound but then drops again. Majority of patients undergoing CPB will demonstrate a post-operative reduction in platelet count secondary to hemodilution and platelet consumption, requiring clinical and diagnostic insight to distinguish true HIT in this population. Baseline platelet count followed by careful report of patient's platelet count trend is paramount in early recognition of HIT rather than relying on an abnormal lab value. Second feature seen in HIT patient is thrombosis. HIT is a prothrombotic state with thromboembolic complication occurring in approximately 1/3 to half of all patients with HIT. Venous thromboembolism is the most common thrombotic complication in patients with HIT, but arterial thrombosis and thrombotic stroke also occur. Patients with HIT are more likely to have serious complication including additional thrombosis, major bleeding, limb amputation or limb gangrene and death compared to patient without HIT. Splenic vein thrombosis, cerebral vein thrombosis are all associated with HIT. HIT associated DIC may also occur manifesting as microthrombosis, decreased fibrinogen and increased fibrin degradation products. Third is adrenal hemorrhage or adrenal insufficiency, which may occur because of adrenal vein thrombosis. This patient may develop bleeding. In patient with HIT, bleeding is not classically seen, but a recent study found that major bleeding occur in 40.6% of patients. Bleeding may be gastrointestinal, intracranial, retroperitoneal or at other sites. Less frequently, patient with HIT may develop heparin induced skin necrosis, limb gangrene or anaphylaxis type reaction following a bolus dose of heparin. Now coming to the variants of HIT, there are two variants of HIT, delayed onset HIT and spontaneous HIT. Delayed onset HIT usually present days to weeks after cessation of heparin and it is driven by antibodies that cross react with the platelet factor 4 glycosaminoglycan complexes and it accounts for less than 5% of HIT cases. It is an important clinical entity and should be considered in any patient presenting with thrombocytopenia or thrombosis who recently received heparin. Second variant of HIT is spontaneous HIT. It is an incompletely understood condition characterized by a HIT-like picture in the absence of heparin exposure and it is likely due to anti-platelet factor 4 heparin antibodies triggered by glycosaminoglycans or other polyanions. In case of spontaneous or delayed HIT, the patient will have a positive functional assay even in the absence of current heparin exposure. Now coming to the pretest probability, the Fortis scoring system is most commonly used scoring system to predict the heparin induced thrombocytopenia. This scoring system gives point for the thrombocytopenia, timing of platelet count fall, thrombosis or other sequelae or other causes for thrombocytopenia. If the score is 1 to 3, then there is a low probability for the HIT. If the score is 4 to 5, then intermediate, and if score is 6 to 8, then there is a high probability for the HIT. Another scoring system is HAP score, that is the HIT expert probability score. This score relies on clinical features which include the magnitude of fall in platelet count, timing of fall in platelet count, thrombosis, skin necrosis, acute systemic reaction or bleeding or other causes of thrombocytopenia. Alternative scoring system in post cardiac surgery patients. Post CPB patients, as we already discussed, that this patient have high risk for HIT and these patients have thrombocytopenia in the setting of heparin for many reasons. So diagnosis of HIT in this subgroup of patient may be challenging. Lilole et al. Described a model for estimating the probability of HIT specifically in post CPB patients and they observed different pattern of thrombocytopenia following cardiac bypass surgery. In this graph, the solid triangle represent the pattern A, thrombocytopenia, which characterized by fall in platelet count following the CPB. Then again platelet count rises within 4 to 5 days of surgery, and then after that again platelet count fall. That is pattern A. In pattern B, which is represented by open circle and characterized by fall in platelet count following the CPB, but this thrombocytopenia persisted following the cardiac surgery. On the basis of this finding, they made the probability score where they use the variables like platelet count time. If there is pattern A thrombocytopenia, they gives 2 points, and if there is pattern B thrombocytopenia, 1 points, and they also include the time from CPB to index date. Index date means first day of suspicion of HIT. So if this time is more than 5 days, they gives 2 point, and if it is less than 5 days, 0 point. They also observe CPB duration. If the CPB duration is less than 118 minutes, gives 1 point, and if it is more than 118 minutes, 0 point. So on the basis of this scoring system, if the score is more than 2, then there is a high probability of hit, and if it is less than 2, then there is low probability of the hit. Coming to the laboratory test for the hit, there are the two categories of the laboratory assay to diagnose hit: immunoassay and functional assay. Immunoassay is the first step and acts as a screening test to rule out hit. Next, a functional assay which establishes the diagnosis. Immunoassay measure the antibodies against the PF4 and the heparin complexes and are the first line laboratory test for the hit. The platelet factor 4 heparin enzyme linked immunosorbent assay, that is ELISA, is a commonly used immunoassay. Immunoassay are accessible, highly sensitive, and offer a rapid result, making them a reasonable laboratory screening tool for patients in whom heat is suspected. However, immunoassay have poor specificity in the range of 30 to 80%. Because of its high negative predictive value, a negative immunoassay rule out hit, but due to low specificity, positive result does not confirm the diagnosis. If the immunoassay, so that's why if immunoassay is positive, so further testing to confirm the diagnosis, usually functional assay is indicated. Functional assay measure platelet activation due to platelet factor 4 heparin antibody binding and cross-linking platelet FC receptors. The serotonin assay, serotonin release assay is the most common functional assay in the diagnosis of HIT, and it acts as a confirmatory test, and it is considered the gold standard. However, the serotonin release assay is technically challenging and the time consuming. It has a sensitivity of more than 95% and superior specificity for HIT compared to immunoassay of over 95% in most cases. A positive serotonin release assay confirms the diagnosis of the HIT. While the serotonin release assay is widely used, some institutions employ the heparin induced platelet activation as the functional assay of the choice. This flow chart showing the algorithm for diagnostic and the clinical management when heat is suspected. So whenever heat is suspected, first we should calculate the 4Ts. We should use the 4Ts scoring system. And if this score is 0 to 3, then we can continue heparin or low molecular weight heparin and consider other causes of thrombocytopenia. If the score is intermediate or high, if it is more than 4, then first we should stop all sources of heparin and start alternative anticoagulation. If patient is receiving warfarin, first we should stop warfarin and reverse with the vitamin K. Then we should obtain immunoassay. If immunoassay is positive, then we should advise functional assay. If functional assay is positive, then HIT is confirmed. If immunoassay is negative, then there is a very less chances of HIT. Now coming to the management of HIT, whenever HIT is suspected or HIT is confirmed, first we should stop the heparin exposure, and first we should stop the heparin exposure. This includes both unfractionated and the low molecular weight heparin flushes, and any heparin coated line or infusion. As heparin induced thrombocytopenia is highly prothrombotic state, so it is important to immediately initiate alternative anticoagulation at a specific treatment dosing for HIT, regardless of the presence of thrombosis. While all HIT guidelines recommend heparin sedation and initiating alternative anticoagulation, the choice of an alternative anticoagulant varies. Alternative anticoagulation for the patient with HIT are direct thrombin inhibitors, direct factor 10 inhibitors, denaparoid, and direct oral anticoagulant. Argatroban is a direct thrombin inhibitor, and it is FDA approved for the use in HIT, and it also recommended by the American College of Chest Physicians and American Society of Hematology for the use in HIT with and without thrombosis. It is usually administered as a continuous infusion at a dose of 0.5 to 1.2 microgram per kg per minute, and for argatroban we monitor the activated partial thromboplastin time, and it should be 1.5 2.5 to 3 times from the baseline. The ergotamine is metabolized in the liver and it is good choice for those with the renal compromise and should be avoided in patients with the hepatic impairment. The second direct thrombin inhibitor is a bivalirudin. It is administered as a continuous infusion, continuous IV infusion. Like ergotamine, its a short duration of effect makes it appealing for those with bleeding risk or those who are undergoing additional procedure intervention and need rapid cessation of the drug effect. It is also FDA approved for patients with the current or previous heat during percutaneous coronary intervention. American College of Chest Physician guidelines recommend the use of bivalirudin for patients with acute or subacute HIT who require urgent cardiac surgery. They are the specific dosing parameter for off-pump and on-pump cardiac surgery as well as for percutaneous coronary intervention. The initial dose of bivalirudin is as an IV infusion at a dose of 0.15 to 0.20 milligram per kg per hour. Bivalirudin is cleared by the serum proteases as well as renal excretion, so it requires dose adjustment in renal dysfunction. Third is fondaparinux. Fondaparinux is a factor Xa inhibitor and it is frequently used off-label for the treatment of HIT. The cross-reactivity with HIT antibodies may rarely occur when treating HIT with the fondaparinux, and it has been speculated that although fondaparinux is capable of inducing HIT antibodies, clinical manifestations are rare because antibodies typically do not recognize platelet factor 4 in the presence of fondaparinux, therefore preventing the required platelet activation. The HIT potential of fondaparinux has been disputed and it is considered a reasonable choice for alternative anticoagulation with the growing popularity. Fondaparinux is renally cleared and kidney function must be considered. Usually it is administered administered by the subcutaneous route and it is, the dose is based on the weight. If weight is less than 50 kg, 5 milligram subcutaneous, and if weight is 50 to 100 kg, then 7.5 milligram. For fondaparinux, we monitor anti-10th level and the target anti-10th level is 0.6 to 1 unit per ml. Denaperoid next alternative anticoagulant is denaperoid. It is naturally occurring low molecular weight heparinoid, that is the mixture of heparin, dermatan and chondroitin sulfate. It is approved for HIT therapy and it is the dose of denaperoid is based on weight and it is given as the IV bolus. And for denaperoid, we monitor anti-10th anti-10th level and target anti-10th level is 0.5 to 0.8 unit per ml. If HIT is suspected and if patient is receiving vitamin K antagonist or warfarin, so reversal with vitamin K should be administered given the risk of warfarin induced skin necrosis and gangrene in the setting of HIT. When warfarin is the long-term anticoagulation choice following resolution of HIT, it is important to bear in mind that initiation of vitamin K antagonist should not be undertaken prior to platelet count recovering to more than 1,50,000. The transition to warfarin requires a period of overlap with the non-heparin anticoagulant. The care should be taken not to overshoot the INR as this has been associated with the warfarin related complication. Now coming to the direct oral anticoagulant. Direct oral anticoagulant include the direct factor 10th inhibitor such as rivaroxaban and apixaban as well as direct thrombin inhibitor dabigatran. Direct oral anticoagulant, particularly rivaroxaban, used as a off-label treatment for HIT. It contains several desirable qualities including short onset of action, no required monitoring and ease of administration. These qualities as well as their lack of any potential interaction between HIT antibodies make them an attractive option both as a primary therapy or as an alternative to warfarin for long-term anticoagulation. Alternative and adjuvant to alternative coagulation. They are the two main alternatives to consider for the treatment of patient with a refractory HIT. One is the plasmapheresis and second one is IV immunoglobulin. Both approach lack systematic evidence but may be utility in challenging cases. Plasmapheresis in the setting of HIT has been described in number of reports both in difficult to treat both in difficult cases or as a new adjuvant approach prior to CPB in patient with the HIT antibodies. There are nearly 30 reported cases of IV immunoglobulin used to treat heat. IV immunoglobulin is hypothesized to work by saturating platelet Fc receptors, thereby inhibiting platelet activation via antibodies. IV immunoglobulin has been described as an effective therapy for cases of the severe and refractory heat. IV immunoglobulin has a potential risk of thrombosis. There are no cases of apparent thrombus extension or new thrombosis in any of the reported cases of heat treated with the IV immunoglobulin. Although the true incidence is poorly understood, this risk must be considered. Indication for platelet transfusion. In patient with the heat or strongly suspected heat, prophylactic platelet transfusion for thrombocytopenia in the absence of bleeding is not recommended. Platelet transfusion may be indicated in case of bleeding or very high bleeding risk. Re-exposure to heparin. Re-exposure to heparin possible in patient with history of heat because anti-platelet factor 4 heparin antibodies are transient. Patient with the remote history of heat weeks to months who are currently antibody negative should not retain immune memory to heparin. And it takes 5 days of heparin exposure to develop heparin antibodies, leaving it possible to reintroduce heparin for less than 4 days without eliciting a second episode of heat. Coming to conclusion, heat is a potentially catastrophic life-threatening complication of one of the ubiquitous medication used in hospital today, heparin. Diagnosis may be challenging and relies on clinical suspicion followed by stepwise testing. It is paramount to stop all form of heparin exposure if heat is suspected and to start alternative anticoagulation. In those patients with heat, decision making about alternative anticoagulation must be based on patient characteristics.